Let's move on. Another case. So today we are learning how a patient with acute HIV presents. We've looked at that. We've looked at how you're even going to separate acute HIV from cytomegalovirus, from Epstein-Barr virus infection, from hepatitis B infection. We've also looked at how a patient who presents with acute HIV, like CNS manifestations, and how we are going to separate that from bacterial meningitis, from viral meningitis, and from tuberculous meningitis. So next question. A 32-year-old woman presents with fever, sore throat, and a maculopapular rash on her face and trunk. She reports recent unprotected sexual contact. Her rapid HIV antibody test is negative. What is the best interpretation of these findings? A, the patient does not have HIV infection. B, the patient may have HIV infection despite the negative tests. C, the patient has a viral exanthem unrelated to HIV. And D, the patient has late-stage HIV infection. What is your answer? Is it A? Is it B? Is it C? Or is it D? I see a lot of doctors, Dr. Tim and the rest on Facebook are all going for B. And the answer is true. The patient may have acute HIV infection despite the negative HIV antibody test. So a negative rapid HIV antibody test does not rule out acute HIV infection, especially in the early stages when antibodies may not be detectable. These patients, symptoms, and we've already learned how a patient with acute HIV will present. We've already learned that. So the patient's symptoms and recent exposure suggest acute HIV infection. And that should be something we will consider very, very seriously. So Dr. Freddy also went for B. The patient may have acute HIV infection despite the negative test. So you always have to remember that there's always that window. There's that window where the patient may be positive but will not show in the rapid antibody test. Okay, next question. A 29-year-old woman presents with fever, sore throat, and generalized rash. So I'm trying to make sure that you get the concept of acute HIV very well. She also has diarrhea and weight loss. She recently had unprotected sex with a new partner. Physical exam shows oral thrush and non-tender lymphadenopathy. Which feature of her presentation is most suggestive? Please listen to the wording carefully. Most suggestive of acute HIV infection. The reason why we teach this way is that so that no matter how the concept is twisted, you still be able to pick it up. So with all these, oral thrush, sore throat, generalized rash, and fever, which of them is most suggestive of HIV infection? Because look, the truth is that almost all of them are suggestive of HIV infection. But which of them stands out that if you see this, you go like, this patient who had unprotected intercourse, because the patient is presenting with this particular symptom, it is likely that the patient has acute HIV infection. Which of them? Which of them? Which of them? Which of them? So let me look at the answers people are putting in the comment section. Oral thrush, sore throat, generalized rash. Dr. Freddy is saying A. Dr. Yitemi is also saying A. Dr. Molola is saying A. Dr. Ronnie rather went for B. What is the answer? The answer which points to acute HIV infection is oral thrush. Now, oral thrush, why did we say oral thrush? Whenever you see an adult who is supposed to be immunocompetent, but that person has oral thrush, it should tell you that the patient is immunocompromised. There are so many conditions which will present with sore throat. So many conditions can present with skin rash, generalized rash. So many conditions can present with fever, right? But when you see an adult who is supposed to be immunocompetent, who has oral thrush, you'll be concerned. So oral thrush is an opportunistic infection which is commonly seen in acute HIV infection because of the transient immunosuppression. So sore throats and rash and fever are also symptoms of acute HIV. However, oral thrush is indicative of a compromised immune system. Doctors, please, does that make sense? Does that make sense? So I'm not saying that sore throat will not be seen in acute HIV, generalized rash cannot be seen, fever cannot be seen. They can all be seen. But of these four, which of them will you say that, oh, this one, it's acute HIV, like the patient has HIV? Because if a patient has infectious mononucleosis, the patient will also present sore throat. If the patient has pharyngitis, sore throat. If the patient has tonsillitis, sore throat. Tonsillar abscess, sore throat. Ewing sarcoma, Quincy, sore throat, right? There are so many conditions which can also present with generalized rash and fever, pneumonia, meningitis, right? But when you see oral thrush, it should cause you. So even if you're in your clinic and you see a patient with oral thrush, it should cause you to think that, no, there's something sinister going on with this particular patient. Okay, let's try another question. So Dr. Itemi says, when you see the oral thrush, it should tell you that this is a point diagnosis, right? Okay, next question. A 45-year-old female with a history of untreated HIV infection presents with new onset of difficulty swallowing and white plaques in her mouth. Her CD4 count is 180 cells per microliter. What is the most likely diagnosis? A, oral hairy leukoplakia. B, Kaposi sarcoma. C, oral candidiasis. D, herpes simplex virus infection. What's the answer? I've seen Dr. Danita saying A. Will somebody go against what Dr. Danita is saying? We are talking about somebody who has difficulty swallowing, white plaques in the mouth. So the question you have to ask yourself is, where does oral hairy leukoplakia usually present? Secondly, where does Kaposi sarcoma usually present? And does it present with white plaques? C, oral candidiasis, where does it present? And then herpes simplex virus, where does it present? When you know these, it will help you to solve this question. So what answer are we going for? I see that Dr. Michael Idris is going with oral candidiasis, while Dr. Itami is also going with oral candidiasis. Dr. Akano is going with oral candidiasis, but Dr. Manuela went with oral hairy leukoplakia. Now, this is the point. The answer is oral candidiasis. And Dr. Manuela, you'll understand why A is wrong. Oral candidiasis is common in patients with HIV, especially when the CD4 count is below 200. And I'm going to show you a table at the end of the class so that you can be able to use it to know, okay, at what CD4 count should I expect this particular condition? If you are preparing for a board exam, that's also something you need to master. The presence of white plaques in the mouth supports the diagnosis. So why is oral hairy leukoplakia wrong? Oral hairy leukoplakia usually presents as a white patch, but it is on the side of the tongue. Let me say it again. Oral hairy leukoplakia, doctors, please pay particular attention. Oral hairy leukoplakia is also white. Oral hairy leukoplakia may also present with patch. But where do you see oral hairy leukoplakia? Usually, it is on the side of the tongue, number one. Number two, oral hairy leukoplakia, you cannot also scrap it off. But with the plaques of candidiasis, they can be scraped off. Number two, why is Kaposi sarcoma not the right answer? Because Kaposi sarcoma does not present with white plaques. Kaposi sarcoma presents with purple or red lesions. So you see, just this word, white plaques in the mouth, can help the good candidate who has prepared for this exam You can help separate that from, somebody who is not very sure, right? So oral hairy leukoplakia, Kaposi sarcoma, what's the difference in presentations? You've got to know all these, all right? Good. Now, what about herpes simplex? Herpes simplex is wrong because it typically presents with painful ulcers or vesicles. It does not present with white plaques. Mastering QE1. Mastering QE1. Mastering QE1 comes with mastering specific concepts. And so that's why I always say that doctors, it is not enough. It is not enough to just read books. It's not enough. It's not enough. So you realize that Dr. Khadija is saying this was esophageal candidiasis, difficulty swallowing. Yes. So it is oral, and it looks like there's an esophageal part as well because the patient is having difficulty swallowing. Next question. Next question. Next question. You have a 50-year-old male with a history of untreated HIV infection and presents with new onset of difficulty swallowing and white plaques in his mouth. Sorry. The patient's CD4 count is 180 cells per microliter. What's the most likely diagnosis? A, immune reconstitution inflammatory syndrome, that's IRIS. B, chronic inflammation and immune activation due to HIV. C, opportunistic infections. And D, adverse effects of antiretroviral therapy. What's your answer? What's your answer? What's your answer? So a lot of people are going with C, 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 C. And the answer is not C. The answer is B, chronic inflammation and immune activation due to HIV. Why? HIV infection is actually chronic inflammation, and it occurs in so many organ systems, okay, which can lead to comorbid conditions such as cardiovascular diseases, even in the absence of severe immunosuppression. So HIV can affect a whole lot of body systems. Why is C wrong? C is incorrect because while opportunistic infections are common in HIV, the context here is about chronic conditions like cardiovascular disease that occur due to ongoing immune activation, not infections. All right. So that is what is happening there. Okay. Next question. You have a 60-year-old man with known HIV infection who presents with fever, cough, and shortness of breath. Now we are getting into the respiratory complications of HIV. His CD4 count is 80 cells per microliter, and a chest X-ray shows diffuse interstitial infiltrates. What is the most likely diagnosis? When you see HIV plus diffuse interstitial infiltrates, are you going to go with A, tuberculosis? Are you going to go with B, pneumocystic geographic pneumonia or PJP, C, bacterial pneumonia, or D, Kaposi sarcoma? What is your answer? What is your answer? What is your answer? Let me see. Dr. Freddy went with C. Dr. Freddy, did you go with C or A? Can you type your final answer? And then Dr. Khadija went with B. Dr. Manuela went with B. Dr. Maria went with B. Celebrating Collins DeSerge went with B. What is the correct answer? The correct answer is B. B. B is the correct answer. Look at the way the concept was described. Diffuse interstitial infiltrates. Diffuse interstitial infiltrate. Now, why is tuberculosis wrong? Most of the time, tuberculosis is not diffuse. Tuberculosis usually presents with upper lobe cavitatory lesions, unless it is the miliary pattern. But when you see the word diffuse interstitial infiltrates, doctors, if you see an HIV patient or an immunosuppressed patient with diffuse interstitial infiltrate, the number one condition which should come into your mind is pneumocystic geographic pneumonia, PJP. Bacterial pneumonia, usually it presents with lobar consolidation, right? Bacterial pneumonia will present with lobar consolidation. Kaposi sarcoma usually affects the skin and mucosal surfaces, and it presents as nodules. We said that it presents as velvety, lesions, not diffuse infiltrates. So today we are learning this concept. Where will tuberculosis present? Usually in the upper lobes, and they may have cavitations. The only time you may see it spread out is miliary TB. How will pneumocystic gyrovectory present? It will present with what? Diffuse interstitial infiltrate. So doctors, please, these are the things I want you to be writing in your textbooks or in your notebooks. How do I pick up PJP? Diffuse interstitial infiltrates. Next question. Next question. A 35-year-old woman with HIV infection on antiretroviral therapy has a viral load of less than 50 copies per milliliter and a CD4 count of 800 cells per microliter. What's the best description of her HIV infection status? A, acute HIV infection. B, chronic HIV without AIDS. C, AIDS. D, HIV controller. 35-year-old patient. Viral load is less than 50 copies per milliliter. CD4 count is 800 cells per microliter. Is the patient having acute HIV infection, chronic HIV infection without AIDS, C, AIDS, or D, HIV controller? What is your answer? Dr. Tim went for B, chronic HIV without AIDS. Dr. Ronnie is going for B. Don't follow anyone's lead, but the answer is it is chronic HIV without AIDS. This patient is on antiretroviral therapy, okay? And it has suppressed the viral load. And the patient has a high CD4 count. So it indicates that the patient has chronic HIV, but the patient has not developed AIDS. Now, I told you at the end of this class, I'm going to show you a table so that you'll be able to use that table to know the 8 defining illnesses as you are preparing for your MCCQE1 exam. Why is acute HIV wrong? It's incorrect because acute HIV infection occurs shortly after transmission. And we've learned some of the symptoms. It can be fever, sore throat, rash, even hepatosplenomegaly, right? Now, AIDS is incorrect because AIDS is defined by CD4 counts less than 200 cells per microliter. So those in MedCognito, you realize that if you go to infectious diseases portal, I've outlined all that's there for you so far as HIV is concerned. There's a whole lecture on HIV, short, straight to the point, right? So if you review that, you realize that all these concepts will be easy for you to answer. And when do you say a patient has AIDS? Number one, if the CD4 count is less than 200, or number two, if the patient has an AIDS-defining condition. And you realize that AIDS defining condition is not present here, and the CD4 count is 800, so it does not qualify as AIDS, right? And HIV controller is incorrect because HIV controllers are individuals who naturally maintain undetectable viral loads without antiretroviral therapy. So this is the difference. And AIDS controller or HIV controller is the viral load is controlled, the CD4 count is high, but the patient is not on antiretroviral therapy. That's an HIV controller. AIDS is defined by CD4 count of less than 200 or an AIDS defining illness. Acute HIV will present with somebody who had exposure, and within a very short time the patient may have sore throat, fever, lymphadenopathy, skin rash, hepatosplenomegaly. But to say that this patient has chronic HIV without AIDS, it means the patient is probably on antiretroviral therapy, and the patient does not have any of the AIDS-defining illnesses. Let's do this question again as well. A 40-year-old man with HIV infection presents with persistent headache and fever. His CD4 count is 40 cells per microliter. What is the most likely opportunistic infection? 40-year-old man. Look at the CD4 count very well. 40 cells per microliter. What's the most likely opportunistic infection? So now the question is basically testing you on your knowledge about CD4 count and various conditions which appear based on the CD4 count. Various conditions which appear. So which conditions are you expecting to see in a patient whose CD4 count is less than 200? Which conditions are you expecting to see in a patient whose CD4 count is less than 100? Which conditions are you expecting to see in a patient whose CD4 count is less than 50? This is what the question is testing you about. So Dr. Sabin went for B, C. Dr. Collins, the Serge went for B. Dr. Amana went for B as well. And Dr. Manuel Idiom also went for B. What's the answer? The answer is cryptococcal meningitis. So all those who went for B, 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 Dr. Freddy also went for B. All those who went for B got it correct. And why do I say that? Cryptococcal meningitis is common in advanced HIV infection with CD4 count below 50. So if I were you, one of the conditions which appear in patients with HIV and their CD4 count is less than 50 is cryptococcal meningitis. Why is cytomegalovirus wrong? Cytomegalovirus retinitis usually will present with visual disturbances rather than the headache. So cytomegalovirus retinitis will present with visual disturbances. Why is toxoplasmosis wrong? Usually, toxoplasmosis will present with focal neurologic deficits and brain lesions seen on imaging. Why is herpes simplex encephalitis wrong? It is wrong because it typically presents with altered mental status, focal neurologic symptoms, temporal lobe involvement on imaging, rather than persistent headache and fever. So, HIV patient, CD4 count less than 50. What one condition, and then the patient has headache, the patient has fever. What one condition should I think about? I should think about cryptococcal meningitis. So Dr. Khadija is asking, what are the specific CD4 counts? As I said, at the end of this class, getting to the end, I have a special table designed so that you can be able to just know which conditions you should go for, okay? Okay. Now, I'm a 28-year-old woman with HIV infection. She presents for her routine checkup. She has no symptoms, and her CD4 count is 650 cells per microliter. She has a history of genital warts. What's the best course of action for managing her HIV? CD4 count is 650, genital warts. What's the best course? A, start antiretroviral therapy immediately. B, monitor CD4 count and viral load every 6 months. C, prescribe antibiotics for potential opportunistic infections. And D, initiate treatment only if CD4 count drops below 500 cells per microliter. What's going to be your answer, doctors? What's your answer? People are going with A, start antiretroviral therapy immediately. And what's the answer? The answer is start antiretroviral therapy immediately. The current guidelines recommend starting antiretroviral therapy for all individuals with HIV, regardless of the CD4 count, in order to suppress viral load and to prevent disease progression and transmission. HIV/AIDS made ridiculously simple, right? Why is B wrong? It's incorrect because while monitoring is important, starting antiretroviral therapy immediately is now the standard recommendation. So that is the thing I want you to go home with today. When people have HIV, the new guideline is start HIV antiretroviral therapy right away. All right, good. Next question. A 55-year-old male with long-standing HIV infection presents with significant weight loss, chronic diarrhea, and night sweats. His CD4 count is 70 cells per microliter. What's the most likely diagnosis? Doctors, A, HIV wasting syndrome, B, tuberculosis, C, Kaposi sarcoma, and D, cytomegalovirus infection. What's your answer? Are you going to go with HIV wasting syndrome? Are you going to go with tuberculosis? Are you going to go with Kaposi sarcoma or cytomegalovirus infection? Dr. Danita went with B, tuberculosis. Dr. Sabine went with D, cytomegalovirus. Dr. Sabine, why are you going with D? The answer is HIV wasting syndrome. The question says significant weight loss, chronic diarrhea, night sweats, significant weight loss. CD4 count is 70 cells per microliter. The reason why HIV wasting syndrome is correct is because HIV wasting syndrome is characterized by significant weight loss, chronic diarrhea, and night sweats. Typically, it occurs in a patient with advanced HIV. And you realize that this patient has advanced HIV, the CD4 count is very, very low. Right? Tuberculosis will usually present with respiratory symptoms. Of course, I know that there are some forms of tuberculosis which may not present with cough issues like Pott's disease and the rest. But in the context of what we are talking about, no. Kaposi sarcoma will present with purple lesions, right? Significant, when we say significant weight loss, chronic diarrhea, night sweats, significant weight loss, chronic diarrhea, night sweats. In the context of HIV, doctors, please think about a patient with HIV wasting syndrome. And cytomegalovirus infection is incorrect because cytomegalovirus typically causes retinitis or colitis, and it will present with specific symptoms related to those sites rather than generalized wasting. So yes, cytomegalovirus may present with some form of diarrhea, but cytomegalovirus itself and alone will not cause significant weight loss.